Okay, thank you very much. Guys, good evening, good afternoon. I hope you're all doing well. I know it's the end of the year and we all wish to be at the seaside with a nice sunset. We have a storm brewing in Gauteng at the moment. So let's hope everything, Eskom was nice to us and they gave us power back. So let's hope it will work. Okay, so this presentation, I'm just going to give you a blink into what clinical pharmacy is. And a big part of clinical pharmacy is pharmaceutical care and medication management and how we do that. And then we're going to go a little bit deeper into the different roles that clinical pharmacists can play as part of the multidisciplinary team in a hospital setting. Patient outcomes that we can achieve with our patients in a hospital setting. So clinical pharmacy is a health science specialty that embodies the application by pharmacists of the scientific principles of pharmacology, of which we know we are the experts, also toxicology of medication, that we know there's no medication that is available that doesn't have toxic effects or side effects, as we'd like to call it, and also the pharmacokinetics and therapeutics that can improve the care of patients. So pharmaceutical care has been defined a lot over the years. The first definition of pharmaceutical care was given in 1975, actually, by a guy called Mikhail. But in South Africa, we have adopted the definition by Professor Linda Strand that she developed in 1997. And that states that it's a practice in which a practitioner, so in this case, it will be the pharmacist, take responsibility for a patient's medication-related needs. So medication-related needs is any medication that we need to perform an intervention with, and the pharmacist holds him or herself accountable for meeting those needs. So accountability means that you are willing to stand in a court of law to say that you have recommended a certain therapy and you are willing to take the responsibility for the effects that medication will have on the patient. So pharmaceutical care is not a function that is unique to a clinical pharmacist. Pharmaceutical care is actually also defined by the South African Pharmaceutical Council in their good pharmacy practice, which is a guide for practice of pharmacists, in that the pharmacist should assume the responsibility of improving therapy outcomes and the patient's quality of life. So if we look at the aims of pharmaceutical care, so what is the aims of pharmaceutical care? What do we want to achieve by this? So we firstly want to provide effective drug therapy. And just if you look here, the effective drug therapy will also entail, will the patient actually take the therapy? So if you dispense, for instance, enoxaparin injections, will they actually use it? So that means, do we actually give therapy to a patient that they will use? Because if the patient won't use it, it will not be effective. Okay, and that can also have a cost implication. The second pillar is safe drug therapy. So safe drug therapy, and we're going to talk a little bit more about this, is the adverse drug events that can happen because of that therapy. Then thirdly, economic drug therapy, which is very important in South Africa, as we are a really resource limited country. So is the therapy affordable to the patient? And affordability does not only mean that we have to give the cheapest generic to the patient, but it can also mean recommending a therapy that is more effective over a shorter period of time. So it might be a little bit more expensive initially, but over the long period, it will be more effective. And lastly, the last pillar is to improve the patient's quality of life. So we have to ask ourselves, what does the patient view as an improved quality of life? So as a pharmacist, we cannot really get the patient a Ferrari if that is what he expects to be an improvement of the quality of life. So we also talk about the improvement of the patient's health quality of life. So what that means is, if we have, for instance, an asthmatic patient that cannot go to work for 3 days a week because he's got a severe asthma exacerbation, can we improve his treatment so that he can live a fairly normal life? So that is what we mean by improvement of the patient's quality of life. So pharmaceutical care involves the process through which a pharmacist cooperates with the patient and other healthcare professionals. So we have to work together in the multidisciplinary team with the prescribing physician, with the patient's caregiver, with the patient's physiotherapist, with the patient's rehabilitation physician, whatever the case may be, to design and implement. And then in the end, that is very important, to monitor the therapeutic plan that will produce a specific therapeutic outcome for the patient. So if we make a recommendation, we have to be able to monitor that recommendation to see if the recommendation that we made as a pharmacist actually had an impact on the patient's life. So if we don't monitor that, we won't know if it really improved the patient's quality of life. So in order to provide quality patient care, the clinical pharmacist must firstly have a knowledge of drug therapy. So as pharmacists, we are custodians of medication, and we are supposed to know what is the possible side effects of a proposed medication or a proposed therapy. We have to know what is the long-term effects of that medication. We have to know what will be the interactions of that medication together with other medications the patients might take. Secondly, we have to have a knowledge of the disease. So to have a knowledge of the disease, it is not to be able to diagnose a patient. That is not the role of a pharmacist. So if we have knowledge of the disease, we purely have to have knowledge of how the medication interacts with that disease process. And will the interaction of the medication have influence on the disease progression, and how the medication will improve the disease's symptoms. Thirdly, we have to have a knowledge of the laboratory skills and diagnostic skills. Again, that is not to be able to diagnose a patient. So pharmacists are not supposed to diagnose. It's not in our scope of practice. So we have to be able to interpret the laboratory results in order to see how the medication interact with the disease progression. Diagnostic skills is just to be able to interpret laboratory results to make certain diagnosis on the grounds of the laboratory results. Furthermore, pharmacists need to have communication skills. And very often we find that patients are very scared to talk to their physicians about questions that they have. So as a pharmacist, we have to have communication skills to explain the medication and their disease condition to patients in layman's terms. But on the other hand, we also have to have the scientific skills to talk to prescribers and physicians and specialists and other members of the healthcare team in a scientific manner. We have to have patient monitoring skills. So how to monitor if the treatment that we suggested or the treatment that the patient is prescribed is actually efficient, cost-effective, efficient, and improving the patient's quality of life. A pharmacist needs to be able to give drug information, both, again, to our patients in layman's terms, so that the patient can understand why it is important to be adherent to the medication, and also to give drug information to prescribers. After all, pharmacists are the custodians of medication. We have to have therapeutic planning skills. So if you approach a patient, how do you approach it that you can systematically evaluate the patient's therapy and to make recommendations on how to make it better? Then physical assessment skills. And if we talk about physical assessment skills, I mean, that's something that I always said, that's why I became a pharmacist, because I don't like bodily fluids and I don't want to touch the patient. So if we talk about physical assessment skills, it doesn't mean that you have to physically examine your patient, but you have to be able to look at your patient and see that your patient is edematous. So if the patient is edematous, a lot of drugs can have an influence through the volume of distribution. So the patient might have a large volume of distribution, which will lower the levels of hydrophilic drugs. So look at your patient, see if the patient is edematous, see if the patient is dehydrated, see if the patient has got an element of jaundice with yellow eyes and a yellow tint to the skin. So that is what is meant by physical assessment skills. And then lastly, we also have to have a knowledge of non-drug therapy. So non-drug therapy entails things like improving the patient's lifestyle, maybe diet, maybe introduce a little bit of exercise. Also know that a patient that has just had for instance, a DVT cannot get up from the bed and start exercising right away. A patient that just had a myocardial infarction, that had a very sedentary lifestyle, cannot start exercising 2 hours a day for the next 7 days. That will probably cause another myocardial infarction. Okay, so comprehensive medication management, that is a word that has been coined in the United States of America, and that's really the same thing as pharmaceutical care. So comprehensive medication management is a standard of care that ensures each patient's medication and I think what is important with the comprehensive medication management, also non-prescription management, so the medication that the patients buy over the counter, also supplements, like if we talk about vitamin supplements, we see a lot of patients with that's taking very high doses of vitamin D, especially after the COVID pandemic. And also in South Africa, very important, herbal supplements and medications that patients get from sangomas or traditional healers. So each patient really needs to be individually assessed to determine if it is appropriate for the patient, if the medication that the patient is taking is effective for the condition, if the medication is safe for use with the patient's concurrent comorbidities and therapies. So if that over-the-counter prescription or over-the-counter medication that the patient buys is safe with his existing comorbidities and therapies, and that the patient is able to take them. So is the patient able to use a suppository correct? Is the patient able to give himself injections in the case of diabetes, or in the case of enoxaparin for patient that needs anticoagulant therapy? So now we can move into the specific functions of a clinical pharmacist. So the first thing is medication reconciliation. So that is a very important role for the clinical pharmacist. So a clinical pharmacist should evaluate all patients' medications, but medication reconciliation is a formal process in which the healthcare provider partner with the patients or the caregivers to ensure accurate and complete medication information transfer at the phases of care. So that is when a patient is admitted to the hospital, it is important to know exactly which medication the patient took, and that includes, again, the over-the-counter medication, the supplements, the herbal supplements. And then when they are moved from one ward in the hospital to the next ward, so when they, for instance, move from ICU to a general ward, and also then when they are discharged from the hospital, so that we call changes in the care setting or the level of care. So oftentimes when a patient are discharged from the hospital, they get a new prescription. And with the many generics that we have in South Africa, we will often see that a patient will get one generic that was on his chronic medication, and when they go home, they will get a prescription for another generic. And then we find it very often that patients actually take the same medication at the same time because they don't know the difference in the different generic names of the medication. So this study was done by a student of us in Dr. George Macquarie Hospital, and she looked at creating and evaluating an opportunity for medication reconciliation in the adult population. So polymedication or polypharmacy is really the use of more than one medication at a time. So anytime that a patient uses more than 2 medications in parallel, that can be seen as polypharmacy. So polypharmacy can create an opportunity for medication reconciliation. Medication reconciliation, for a pharmacist are ideally suited, and they have the in-depth knowledge on the pharmacokinetics, pharmacodynamics, and medication interactions to optimally perform medication reconciliation. So with the process of medication reconciliation includes to ascertain that all the medication that the patient is using are indicated for the appropriate condition of the patient. With medication reconciliation, we can consider the overall risk of the medication-induced harm, and that will require the intensity of deprescribing. So deprescribing is really to reduce the medication load for the patient. So during medication reconciliation, we have to assess each medication's current and future benefit for the patient, and we have to compare that to its potential for current and also future harm. So some medications, if I think, for instance, about the proton pump inhibitors that we previously thought were very safe. I mean, I remember when I was still working as a pharmacist in a hospital, and when it was launched, and they assured us that this is the most safe medication on the market. And then years later, with post-marketing complaints that were got, a lot of things were added to the label of the proton pump inhibitors. For instance, it has the possibility to cause renal impairment. It has the possibility to cause micronutrient deficiencies. We think about vitamin B12 deficiencies, magnesium deficiencies. It has the possibility to increase the occurrence of Clostridium difficile infection in patients because it is lowering the gastric acid content. Then we have to prioritize medication for discontinuation with the lowest benefit to harm ratio and the lowest possibility for adverse reactions and the disease rebound syndromes. So for instance, if we think about something like the histamine 2 receptor antagonists, the guidelines state that most of the histamine receptor 2 antagonists can be used for 1 month to 6 weeks, and that should clear up the disease condition. But then they found, studies have found that within 1 year, those patients will relapse into the gastroesophageal reflux disease or the peptic ulcer disease or whatever the initial diagnosis was. So we really have to weigh which medication to discontinue and how to monitor the patient closely for improved outcomes, and which adverse effects we can live with and monitor the patient for that. Okay, if we move on to medication errors, a medication error can be an error that considered the error occurring at any stage in the medication process. And the medication process includes prescribing, ordering, transcribing prescriptions, which we see a lot in the emergency department settings as well as settings, the ordering of medication, documenting, then the dispensing, administration, and the monitoring of medication. Okay, so if we observe medication errors, the most errors have been found in administration of medication. Then also dispensing showed about a third, of the medication errors. Prescribing accounts to about 28%, and then transcription to about 5% of the medication errors. Studies found that at least one error that can result in a potential or an actual preventable adverse drug event happens for every 5 doses of medication that is administered. So the medication errors leading to potential adverse drug events mostly occur in the administration and the dispensing stages. So medication errors, the most common type of medical errors in the ICU or the hospital is medication errors, and they may result in patient injury. It can result as a benign or transient abnormal lab value or maybe a rash to the patient, but it can be as significant as end organ damage. If we think about someone that is receiving multiple medication that can cause injuries to the kidneys, for instance. 25% of medication errors will actually result in adverse drug events. So adverse drug events, we can again break down into preventable adverse drug reactions. So that is somewhere where we can stop the medication from reaching the patient. Or it can lead to potential adverse drug events that we also call near misses. That is, for instance, where a patient has a penicillin allergy and they have been prescribed the penicillin, or they have been prescribed one of the other carbapenems that can have a cross reaction. But the patient received the medication and didn't have an immediate reaction. And then lastly, we can also have non-preventable adverse drug reactions. And that is somewhere where the pharmacist can play a role to really manage those patients. So that is, for instance, if we think about cancer patients receiving the cisplatins or the drugs that really cause a lot of kidney injuries, but we have to know how to manage it. So what can we do for that patient to lower the event of an adverse drug reaction? The Pharmaceutical Federation actually declared that pharmacists should be involved in patient safety from the prescribing phase of medication up to the administration of medicines. So patient safety, as defined by the Pharmaceutical Federation, is seen as the prevention of harm to patients, and that's including harm through the errors of commission, so where a patient is prescribed the medication, as well as omission. So if we talk about it a little further, you will see that omission of medication can be regarded as a very large medication error. So this study was done in a large tertiary academic hospital, and it was identifying medication errors in a neonatal intensive care and the pediatric wards of the hospital. They actually found 663 medication errors in 227 patients over a period of 4 months. So you can see that that concludes to about 3 medication errors per patient. They found that clinical pharmacists monitoring medication orders may prevent more than 50% of all medication errors and more than 72% of potentially harmful errors to reach the patients. They also suggested that improved doctor-pharmacist communication can increase the prevention of medication errors by almost half. An adverse drug event can be considered an injury that is caused by medication. Adverse drug events can be associated with hospital and admissions, and they can be reduced by using medical record reviews on admission, as well as patient interviews to identify patients who had previous adverse drug reactions. So almost half of patients identified in one study have experienced an preventable adverse drug event. So we can also split it then in preventable adverse drug reactions, and that is injuries that are caused by drugs that are associated with medication errors. And if we can actually catch those medication errors before it reaches the patient, we can prevent the adverse drug reaction. And then we do have non-preventable adverse drug reactions, and that is injuries that is caused by drugs that are associated without medication errors. So that is adverse drug reactions that we can expect with certain medications. I think about something like, I know the prescribers, the doctors like to call it amphotericin B. Amphotericin B that we know is needed in some fungal infections, and that can be prevented. The severe kidney injury and the allergic reactions in those patients can be prevented by making sure that your patient is adequately hydrated before we actually administer the amphotericin. Then injury can be defined as end organ damage. So that can be a possible endpoint. So any adverse effect or side effect that can be caused by a medication can be seen as an adverse drug reaction. If we look at therapeutic drug monitoring, and that is really an expert field, so therapeutic drug monitoring is a very important aspect in clinical medicine, and it can contribute significantly in the monitoring of patients and the use of their medication. As soon as the serum blood concentrations are available, the clinical pharmacist will be responsible to interpret the results and make the appropriate recommendations to the physician regarding the dose and the dosing interval of the drug. So we really have to look at the patient and see what is necessary. Important recommendations include that we need to develop a new regimen of the drug dose. So we might have to lower the dose or increase the dose if we think about augmented renal clearance, for instance. We might reduce or increase the dosing interval or even the route of administration for specific patients. Patient-specific factors that are considered when therapeutic drug monitoring are needed include the patient's age, the patient's weight, so the weight will have an influence on the volume of distribution of drugs, and then lastly, the renal function of the patient. So renal function is very important to determine the build-up of toxic metabolites in the patient. Visualize pharmacokinetics for each patient regarding the volume of distribution of drugs as well as the clearance of the drug, so that we will consider a patient's impaired renal clearance or augmented renal clearance. Okay, antimicrobial stewardship, I think, is something that I don't have to say too much about, but it is a large part of the clinical pharmacist's responsibility. So it is well documented that antimicrobial resistance is a growing health problem, and the monitoring of evolving local trends is needed. So if I talk about local trends, it means the trends in your specific hospital, and it can actually be narrowed to the specific unit the pharmacist is working in. The clinical pharmacist, as a suitably skilled healthcare professional, is pivotal in giving support in clinical decision-making, infection control interventions, antimicrobial stewardship programs, and the antimicrobial resistance control strategies. The clinical pharmacist forms an integral part of the multidisciplinary healthcare team, and they can play an active role in formulary compliance and influencing prescribing patterns of antimicrobials in the hospital setting. So the ideal composition of the multidisciplinary antimicrobial stewardship team should include an infectious disease physician, the clinical pharmacist, a clinical microbiologist, an infectious disease nurse, a hospital epidemiologist, and then also administrative support personnel. So as we know, in most of our hospitals, especially if we looked at district hospitals or regional hospitals, they really don't have all of these expertise available. But most hospitals do have a pharmacist, they do have a physician, and between the two of them, if they work together, they can make an effective antimicrobial stewardship team. Most hospitals in the South African setting lack the specialized resources, and in many settings, a pharmacist can lead the antimicrobial stewardship program. A dedicated infectious disease pharmacist may effectively lead the antimicrobial stewardship team and improve the adherence to recommended antimicrobial practices. So that has been shown in many studies that has been done over the last 10 years in South African hospitals, both in the private sector as well as the public sector. So pharmacists and registered nurses can also run an effective to obtain adequate antibiograms from the labs, as well as look at doses and effective antibiotics like duplication of therapy, where antibiotics are used too long for when we think about antimicrobial surgical prophylaxis and things like that. So the Center for Disease Control and Prevention identified the following essential pharmacy interventions and the role a clinical pharmacist can play. I just want to mention here that in order to be able to do these antimicrobial stewardship interventions, you do not need to be a qualified clinical pharmacist. We've seen many occasions where pharmacists with an interest and that really wants to do this can also do these interventions. So the first one is to switch from intravenous to oral therapy. Intravenous, and that can improve patient safety because we take away the intravenous therapy of the patient, and that can also reduce the risk of multiple drugs being administered intravenously. We can look at dose adjustment in organ dysfunction, for instance, in renal or hepatic impairment. We can look at dose optimization for highly drug-resistant bacteria, so to ensure that central nervous system penetration when patients have meningitis. We can optimize the infusion times of certain antibiotics to increase the pharmacokinetic, pharmacodynamic parameters. And we can base these optimizations on therapeutic drug monitoring. We can identify and alert prescribers where therapy may have duplication of spectrum. We can discontinue instructions for specified antibiotic prescriptions, for example, those used in surgical antimicrobial prophylaxis. And then lastly, we can identify antibiotic-related drug-drug interactions. So pharmacists has also been able to play a role in different settings in the hospital. So in critical care, interventions suggested during the ward rounds supplied a good platform for discussions regarding the use of antimicrobials and other medicines or specific doses of the medicine. So the number of medicines prescribed to the patients admitted to the ICU provided an opportunity for pharmacists to perform numerous interventions, and the conclusion can be made that the continued presence of a pharmacist in the ward in the ICU setting would be beneficial to patient outcomes, as well as having a cost-saving benefit. Also, in the renal unit, for instance, clinical pharmacists should emphasize the importance of drug dosing adjustments in patients with renal impairment, especially if it is chronic renal impairment. The major role of the clinical pharmacist in the neonatal intensive care unit will ultimately be to prevent medication errors. As the neonatal population is especially vulnerable, therapy should be tailored to the needs of the individual patient, ensuring that doses and dosing intervals are appropriate according to the patient's weight. The need for calculations of pediatric doses and the increased need for dilutions of pediatric medicines. And then I can maybe add also that there's a lot of medication that we have to administer to pediatric patients that do not necessarily have pediatric formulations. Provide greater opportunities for clinical pharmacists to optimally manage medication in this setting. So evaluation of medication therapy entails the pharmacist to identify specific strategies to optimize the medication therapy by assessing the appropriateness of medication, to evaluate the effectiveness of medication, as well as the safety. And then lastly, I think very important in South Africa is to evaluate the affordability of medication of the patients. Pharmacists can monitor patient outcomes by looking at alleviation of specific symptoms that patients are experiencing, for instance, pain and fever, or even normalizing the patient's hypertension. We can look at improvement of the disease condition. So like I mentioned in the beginning, if a patient has 3 asthma exacerbations a week and he couldn't get to work because of that, can we get that asthma exacerbations under control? We can look at improvement in laboratory results, and there I think about things like serum glucose levels. If we can optimize a patient's therapy to treat his diabetes, can that have an influence on his laboratory results and even his HbA1c over a period of time? And then we can look at the reduction of a patient's hospital stay. So can we have an influence to get the patient's discharge from hospital earlier? And then also look at the readmission rate of patients. Specifically, maybe something we can look at is to reduce the number of patients coming back with surgical site infections. So in conclusion, the multidisciplinary healthcare team need to be more aware of the incidence and importance of medication errors. And also the drug events in medicated patients. So the drug events that can happen because of medication errors, and also drug events that is not preventable. The clinical pharmacist can be ideally situated to do active patient safety surveillance and to improve reporting of medication errors and adverse drug events. The clinical pharmacist can also document severe and unusual reactions by reporting to SAPRA and the Department of Health. And here I just want to say, at the moment, the reporting of adverse drug events is really very poor. And sometimes people are scared to report medication errors and adverse drug events because of fear of retribution. But this is a very important function of the clinical pharmacist. So lastly, many studies have proved the improvement in patients' quality of life with the inclusion of a clinical pharmacist as part of the multidisciplinary healthcare team. So maybe also just to mention that the clinical pharmacist is really not there to be a policeman, to look at other professions like nurses and doctors and see where they make mistakes, but the clinical pharmacists are really there to improve patient outcomes and to improve the patient's quality of life regarding their healthcare needs. Okay, and that's the end of my story. I thank you very much for the opportunity, and I am happy to answer any questions you may have.
Thank you, Prof. Thank you very much for a so informative presentation. Because we left about 10 minutes, maybe I'll just start taking the questions. Dr. Mawela, do you want to start or are you okay?
No, just to really appreciate this presentation. And I think as Prof was going through the talk, I realized, okay, this is a very, very, very loaded topic, you know, which we need to really, you know, engage with. I think maybe for me to start, and then Refilo, maybe you can have follow-up questions, Prof, is to talk about, because I'm a medical doctor myself, and I work with pharmacists, you know, like Refilo, and also on World AIDS Day, I was part of the SAHIP World AIDS Day conference talking to pharmacists about how we can work together. So where do we start, Prof, with regards to improving the communication between doctors and pharmacists? I know about the fights between the two disciplines. You know, when a pharmacist picks up something, having to call the doctor. Sometimes even doctors might feel that pharmacists are also encroaching on their scope. I don't want to go into the details, but I'm sure, Prof, you know the issues there. But if we are to get the interdisciplinary approach right, and maybe the importance of improving the communication, where do we start tomorrow? Thanks, Prof.
Yes, that's a very good question. But I think the bottom line is that we have to realize that there's really an important relationship between pharmacists and doctors, and each of us have a role to play. So I think the sooner pharmacists can realize that they're not the policeman of the doctor, and that we really work together in increasing patient experience in our hospitals, the better. On the other hand, the prescribers or the doctors should also realize that the pharmacist is not there to be a policeman and to show them on their mistakes. The pharmacists are really also there to improve the quality of care of our patients. So I think that it's a two-edged sword. So we really have to, I think the bottom line is relationship building. So once the prescriber can start trusting the knowledge of the pharmacist, and the pharmacist can be there just for patient improvement and not to prove something, that will be a start. But I think the bottom line is relationship building. So if we can all build the relationship in a multidisciplinary team, that can benefit our patients.
Superb. Let me ask Refilo too. Thanks, Prof, for that. I see by the emojis that were shared when you were talking about the topic. I think it's just that topic. It's probably close to everyone's heart, and it's something that we all need to work hard to improve in the interest of patient care. Let me ask Refilo to ask few questions, and then we will come back to 1 or 2 questions I have. Maybe we can continue, colleagues who are here, until 7:10. Yeah, so please be patient as we engage. We need to engage on a few questions. Thanks, Refilwe.
Thanks, Dr. Mawela. Prof, the first question is, while it is true that we cannot as pharmacists diagnose as a measure function, but PCDT pharmacists can do that, but to a limited extent. What's your take on this? Clinical pharmacy and PCDT.
Oh, okay. So PCDT is really something separate. So I think clinical pharmacy has got a large role to play in the hospital setting, where we can be part of the multidisciplinary team. With primary care, I missed who asked the question, but as he said, it's really limited. So it's really because we have a overwhelmed public health system. There, the pharmacist can play a role in identifying minor ailments and maybe also prescribing. I think what is important for the PCDT pharmacist is to know when it is serious enough to refer the patient to a higher level of care. That is also an important function. And I think that also goes for retail pharmacists, where they treat patients with over-the-counter medicine. They should really be very wary of when patients need to be referred to a higher level of care.
Okay, thanks, Prof. I think this one has been answered already from Dr. Mawela's question, but it was more if you from your side, do you think that doctors and pharmacists are working optimally now in both sectors, private and public, now or long time ago? So I think, Dr. Mawela, you did try and answer that from Dr. Mawela's question. I'm not sure if you want to take to respond to it.
Yeah, I think in some institutions it's better than in others, but I think we still have a long way to go. Also, the workload of both pharmacists and prescribers, especially in the public healthcare sector, is just as such that pharmacists and doctors don't really get to work together. So we really have a long way to go.
Prof, if I may chip in there, I mean, you have described, the clinical role of pharmacists, but I find that pharmacists spend most of their time dispensing and general administrative processes, for the pharmacy services. Therefore, the majority of the things you have listed, I haven't seen pharmacists participating. I've actually had one clinical ward round with a pharmacist, and I always refer to that particular experience as the most rewarding experience for me as a clinician with regards to the choice of treatments and stuff, but ultimately for the patient. But in my 18 years as a doctor, I've only had a ward round with a pharmacist just once. So I don't know, Prof. Is it time management? How do we help a pharmacist? Is it time? I understand the workload, but how do they get to spend a little bit more time in that space? Thanks, Prof.
That's a very difficult question. Well, it will depend where you are based, and then also it also depends a lot on the interest of the pharmacist to really get involved in patient care, in individualized patient care. And maybe if that pharmacist is still with you, it will be great if you can invite them for another ward round and just get them involved. But that is something, clinical pharmacy in South Africa is still really in its infancy shoes. So we've been training clinical pharmacists maybe for the last 15 years in South Africa. So it's really a new specialty for pharmacists. And in saying that, we also don't have the majority of pharmacists are not clinically trained. Although you don't always need to be clinically trained to be able to make a difference at the patient's bedside. So yes, yeah, it is a conundrum. So what do we do? Do we have pharmacists only dispensing, or I think there are some public hospitals that are making progress with automated dispensing systems, freeing the pharmacist to do more patient counseling and interacting with the multidisciplinary healthcare team. But again, that's something that's got a long way to go before we get the ultimate multidisciplinary team.
And I see Obey, funny enough, he's saying that he works in the public sector. He wants to start, but he needs practical guidance. So checklists and protocols. I'm not sure whether clinical guidelines as written are written for doctors. I guess it's for all teams, but he seems to be struggling with, I don't know how to start. He says the practical guidance on how Obey. I wish you could raise your head so that we can hear your voice, but yeah, I don't know, Prof, anything else you can give Obey as an advice?
Yeah, so there's a lot of guidelines that are available, but again, a guideline is just a guideline. And as a clinical pharmacist, you really have to be able to assess a patient on an individual basis. So for clinical pharmacy, we really assess individual patients. So the guideline is there, but individual patients sometimes need treatment that is outside of the guideline. And I think that is sometimes where pharmacists and clinicians bump heads, because the pharmacist will want to be very strict on the guideline, and the clinician might see something different that needs to go outside of the guideline. So I think as pharmacists, we also need to be aware of that you really need to individualize patient care. So my suggestion on how to start is just to start small and start building a relationship with a prescriber in your hospital setting. And through that, working together with a prescriber, if a pharmacist and a prescriber can start working together, you will learn a lot from each other.
Okay, thanks, Prof. Because I see colleagues, I see you posting your questions under the chat box. Please post them under the Q&A box, because now I have to read 3 screens so that I can see your questions. But I think, Prof, there's another question that is supplementing what has been discussed just now in terms of incorporating all the elements in that spider diagram in terms of patient care. So with the large volume of patients, how do we do that? How to incorporate those elements in the spider diagram, considering the number of patients that we are seeing in a public sector?
And maybe, Prof,
yes.
Yeah. So sorry about that. I was saying also, I see a lot of questions related to people who say they are not clinical pharmacists, but they are practicing clinical pharmacy. So maybe as you respond to the time, maybe also respond to, is this a discipline? Is it something that all pharmacists can practice? And whether we do have some clinical pharmacists in the public sector, I don't know. I think they are related in a way. Thanks, Prof.
Okay, so yeah, that's a loaded question. So all pharmacists should be able to practice a degree of pharmaceutical care, at least. Okay. So what I want to say, if you look at the huge amount of patients that we have, especially in the public sector, it seems like a mountain we cannot climb. But my suggestion would be for you to start small. Like I said, build a relationship with one prescriber. Choose one ward in your hospital. Don't try to see all the patients. I mean, even experienced clinical pharmacists, it is very difficult to see 360 patients every day. So there are, maybe that can be a follow-up discussion, but there are ways that you can identify which patients to look at. So either choose a specific ward, choose the ICU or choose the medical ward, or if you want, choose the orthopedic ward where there's smaller interventions to be made, and then start building your practice from there. We really, I'm honest, even experienced clinical pharmacists cannot see on their own each patient in the hospital. You can also look at high-risk patients. So if you know patients that's got a lot of medication, so there's polypharmacy going on all over the show, patients that has got more than one prescriber. We often see that patients with a surgeon, a physician, a nephrologist, a pulmonologist, whatever, and everyone wants to write their own prescription. We often find drug interactions or overlapping of spectrum in those medications. So decide how you want to do it, identify the patients that you want to see, and start small with 3 or 4 patients per day, and then build from there. And then if you're not sure, it's okay to ask. I mean, you can provide my email address. People are welcome to ask questions if they have a specific patient-related question.
I have just one question. I'm just going to combine the questions and just put them into one. A clinical pharmacist stewardship at primary healthcare level where the clinic is nurse-driven when there are no doctors. So how do we implement a clinical pharmacy in those settings? And how far will a pharmacist assistant play a role in that aspect when we implement clinical pharmacy in a nurse-driven primary care facility? And also the last one is communication within the multidisciplinary team. How can we make this happen? So basically, I think these are the last questions that you will have to just address for us. Thanks.
Okay, so I don't think I'm really qualified to comment on a primary healthcare system driven by a nurse. I think what is important for primary healthcare, what is really important is to be able to know when you can use the standard treatment guidelines to treat those patients, because that is the function of a primary health clinic, really, is to know when we can. It's a simple condition where the nurse can diagnose the simple condition and treat, and then again, know exactly when you need to refer to a higher level of care. And then the last question was about the communication, right?
Yes. Yeah.
And I think that is where the pharmacist, and I think most pharmacists should be able to do that. I spoke about the communication where you as a pharmacist should be able to speak to your patient in more layman's terms, because that's often what we get from patients, is that when they talk to a prescriber or a doctor, they don't understand what the doctor is saying. So as a pharmacist, we should be able to explain to them the basics, and then also be able to speak to the prescriber in a more scientific way. And then I think the basis of communication is really relationship building. So the better your relationship with the prescriber or the patient, the easier you will be able to communicate.